we had a question come in. Can anyone elaborate on IRF coding? Now, this was pretty interesting because I had to do some research on IRF coding. It wasn't something I was familiar with. So what does IRF stand for? The first thing you need to know is it's Inpatient Rehabilitation Facility Coding. So it is kind of an all different, I want to say a different ball game is what I'm trying to say. It can be a challenge due to Medicare Inpatient Rehabilitation Facility Prospective Payment Systems. Now, the acronym for that is IRF PPS. And this was implemented way back in 2002 to cover patients paid under Medicare Part A. What this IRF PPS requires is a completion of the IRF-Patient Assessment Instrument. Now, I'm going to be repeating this more and more, but I'm just going to use the acronym, and that is called a PAI. It's a data collection form that's completed on admission and discharge, all right? The conditions reported on the UB04, and that's how that's the form that's sent in for inpatient billing, and the IRF-PAI differ, and as do the guidelines for the code assessment, all right? And so these two forms, it kind of butts heads, as we'll show you here in just a minute. So they don't always match, okay? So what you put on the form to get paid for inpatient, the UB04, and what's put on the IRF-PAI is, they aren't going to be the same a lot of the times. So a measure was developed by the AAPMR way back in the 80s, and the American Congress of Rehabilitation Medicine did this. It is the FIM, or Functional Independence Measure. All of these abbreviations can really get you. Now, there is a link to these. There's a training manual that you get, this prospective payment system. You can look at that, and that's what's used to fill out these forms. So what is actually a PAI? CMS provides payment for inpatient rehab facilities through a case mix groups, okay? Now, what they're going to do is the information is collected on the IRF-PAI during the first 3 days of admission, okay, when they first get there, and then they include on this the impairment that the patient has, the FIM score, and the age of the patient. Those are all pertinent. And this information is used to classify the patient into a case mix, group, all right? And there are 4 payment tiers to each case mix. That's important to know. Well, when you get to doing this IRF, there's a lot of challenges that I found. The guidelines change, and they're not in the training manual on a timely basis. You know how the manuals we get for our coding come out every year? Well, this is a different, like I said, a different ball game, and it doesn't come out in a timely manner. There's limited education available. The training is not focused on ICD-9 assignments. So the training that you do get is training not how to code like you would get with ICD-9 training. It's just about pretty much how to fill out these forms. They have different guidelines. The IRF PAI have different guidelines than the UB04 form. Now, if you've never looked at a UB04 form, it's similar to the CMS 1500 that we're used to for physician-based billing, except for that it's longer because it allows for it allows for a lot of diagnoses in there. So you can imagine what you've got the UB04 form, and then what the IRF PAI looks like. The documentation doesn't always focus on impairment and etiology. that's one of the problems in the documentation that they're given, and that's what the IRF-PAI is based on. And the communication between the clinicians and the coders can be a problem when you're dealing with the IRF-PAI. So example of reporting. This was an excellent example of how this would happen. Condition first discovered or identified on the day prior or the day of discharge are reported on the UBO4, but not on the IRF-PAI. The conditions reported as acute by a short-term acute care hospital are reported as status post or late effect, etc. That's the way they're going to be reported. This is confusing for coders that code for both an acute care hospital and a rehabilitation facility or unit. The code reported on the UBO4 as the principal diagnosis, say V57.89, admission for rehabilitation, is not reported on the IRF-PAI because it does not provide diagnostic information, does it? Well, there's more. An example of a communication problem, a patient who is admitted following a CVA and a hip fracture. Either impairment could be reported by the IGC. If the hip fracture is reported as the impairment, the etiology should be reported with a code for hip fracture. Clinicians and coding professionals need to effectively communicate so sufficient documentation is available to support accurate code assignments. And that is very important when we're dealing with these two separate identities or entities, not identities, entities. What should a coder do? Well, here's a few things to keep in mind. Stay up to date with the CMS changes that affect the code assignments. All right, so that means be on top of ICD-9 and ICD-10. 10. Keep current IRF training manual. So you always want to have the current, when all the new stuff comes out, you have the new manual. Keep current on conditions in the 75% rule, and network with others. Again, that is across the board. Any type of coding that you do, you want to have a network in place so that you guys can assist each other. I just wanted to make a point that this Patricia Triella is her article that she wrote was absolutely fascinating, and where I got most of this information. Very knowledgeable. I enjoyed it very much, reading and learning more about that.
Do you need more medical certification training? Go to www.cco.us. And don't forget to subscribe to our YouTube channel for updates.